patient fits a precise physiologic classification of shock before initiating appropriate volume restoration. Initiate hemorrhage control and balanced fluid resuscitation when early signs and symptoms of blood loss are apparent or suspected, not when the blood pressure is falling or absent. The physiological classification system for shock is helpful, but these following factors can confound and profoundly alter the classic hemodynamic response to the acute loss of circulating blood volume. Initiate hemorrhage control and balanced fluid resuscitation when early signs and symptoms of blood loss are apparent or suspected. Major soft tissue injuries and fractures compromise the hemodynamic status of injured patients in two ways. First, from blood lost at the site of injury, particularly in major fractures, and second, from edema in injured soft tissues. Tissue edema is the result of shifts in fluid, primarily from the plasma into the extracellular space. These shifts cause an additional depletion in intravascular volume. The diagnosis and treatment of shock must occur almost simultaneously. For most trauma patients, begin treatment as if the patient has hemorrhagic shock, unless a different cause of shock is clearly evident. The basic management principle is to stop the bleeding and replace the volume loss. The physical examination is focused on diagnosing immediately life-threatening injuries and assessing the ABCDEs. This would include rapid control of hemorrhage, exposure of the patient to assess all injuries, and preventing hypothermia to limit coagulopathy. Baseline recordings are important to monitor the patient's response to therapy, and measurements of vital signs, urinary output, and levels of consciousness. A more detailed examination of the patient follows as the situation permits. Remember, the primary focus of treatment is to promptly identify and stop bleeding. Review the various methods of stopping hemorrhage. Gastric dilation often occurs in trauma patients and can cause unexplained hypotension or cardiac dysrhythmia. In unconscious patients, gastric distension increases the risk of aspiration of gastric contents, a potentially fatal complication. Consider decompressing the stomach and applying suction. Bladder catheterization allows clinicians to assess the urine for hematuria, which can identify the retroperitoneum as a significant source of blood loss. Monitoring urine output also allows for continuous evaluation of renal perfusion. Obtain vascular access immediately. The rate of flow is explained by Poiseuille's law. Short, large caliber peripheral IV lines are preferred for the rapid infusion of fluid rather than longer, thinner catheters. Use fluid warmers and rapid infusion pumps in the presence of massive hemorrhage and severe hypotension. As intravenous lines are started, draw blood samples for type and cross-match, appropriate laboratory analyses, toxicology studies, pregnancy testing when appropriate, and blood gas analysis. The amount of fluid and blood required for resuscitation is difficult to predict on initial evaluation of a patient. Administer an initial warmed fluid bolus of isotonic fluid. Then assess the patient's response to fluid therapy, looking at end organ perfusion and tissue oxygenation. Further therapeutic and diagnostic decisions are based on your observation of patient response. Early resuscitation with blood and blood products must be considered in patients with evidence of class 3 and 4 hemorrhage. Early administration of blood products at a low ratio of packed red blood cells to plasma and platelets can prevent the development of coagulopathy and thrombocytopenia. In penetrating trauma with hemorrhage, delaying aggressive fluid resuscitation until definitive control of hemorrhage is achieved may prevent additional bleeding. Balancing the goal of organ perfusion and tissue oxygenation with avoiding rebleeding by accepting a lower than normal blood pressure has been termed controlled resuscitation or balanced resuscitation. This strategy may be a bridge to, but is not a substitute for, definitive surgical control of bleeding. Normal blood pressure, and pulse rate are signs that perfusion is returning to normal. But these observations do not provide enough information regarding organ perfusion and tissue oxygenation. Urinary output is one of the prime monitors of resuscitation and patient response. The inability to obtain urinary output at adequate levels or a decreasing urinary output suggests inadequate resuscitation. In this case, additional volume replacement and continued diagnostic investigation is needed. Remember, severe metabolic acidosis can develop from long-standing or severe shock. Base deficit and/or lactate values can help determine the presence and severity of shock. Then, serial measurements can be used to monitor the patient's response to therapy. The potential patterns of response to initial fluid administration can be divided into these three groups: rapid response, transient response, and minimal or no response. Patients in this group, referred to as rapid responders, quickly respond to the initial fluid bolus and become hemodynamically normal. Once this occurs, you can slow the fluids to maintenance rates. No further fluid bolus or immediate blood administration is indicated. However, typed and cross-matched blood should be kept available. Obtain surgical consultation and evaluation because operative intervention could still be necessary. Transient responders respond to the initial fluid bolus, but then show deterioration of perfusion indices as the initial fluids are slowed to maintenance levels. This response indicates ongoing blood loss or inadequate resuscitation. Transfusion of blood and blood products is indicated, but even more important is recognizing that such patients require operative or angiographic control of hemorrhage. Also consider initiating a massive transfusion protocol. Failure to respond to fluid therapy dictates the need for immediate, definitive intervention, such as an operation or angioembolization to control hemorrhage. Non-hemorrhagic shock always should be considered as a diagnosis in this group of patients, and advanced monitoring techniques are useful to identify the cause of shock. Massive transfusion protocol should be initiated in these patients. The main purpose of blood transfusion is to restore the oxygen-carrying capacity of the intravascular volume. Fully cross-matched packed red blood cells are preferable for this purpose. When unavailable, type O packed red blood cells are indicated. The most efficient way to prevent hypothermia in patients receiving massive fluid resuscitation is to heat the fluid to 39 degrees Celsius before infusing it. Adaptations of standard tube thoracostomy collection devices are commercially available, allowing for sterile collection, anticoagulation, and transfusion of shed blood. A small subset of patients with shock will require massive transfusion. A massive transfusion protocol that includes immediate availability of all blood components should be in place, because extensive resources are required to provide these large quantities of blood. Injury and hemorrhage result in the consumption of coagulation factors and early coagulopathy, which is present in up to 30% of severely injured patients. Massive fluid resuscitation then contributes to coagulopathy. Obtain baseline prothrombin time, partial thromboplastin time, and platelet count values in the first hour. Some jurisdictions administer tranexamic acid in pre-hospital setting to severely injured patients in response to studies demonstrating improved survival when administered within 3 hours of injury. Patients with major brain injury are prone to coagulation abnormalities, so coagulation parameters need to be closely monitored. Hemorrhagic shock requires correcting inadequate organ perfusion by increasing organ blood flow and tissue oxygenation. An increasing blood flow requires an increase in cardiac output. However, an increase in blood pressure should not be equated with an increase in cardiac output or recovery from shock. Several of the physiologic changes with aging affect the older trauma patient's response to shock and its treatment. These include poor tolerance to hypotension secondary to blood loss, pre-existing volume depletion, medication use that can mask signs and adversely affect the stress response to trauma, and reduced pulmonary compliance and general weakness of the respiratory muscles, limiting their ability to meet increased demands for gas exchange imposed by injury. For all of these reasons, the mortality and morbidity rates increase directly with age. Because the therapeutic range for volume resuscitation is relatively narrow in elderly patients, consider using early advanced monitoring to avoid excessive or inadequate volume restoration. Rigorous athletic training routines change the cardiovascular dynamics of this group of patients, affecting blood volume, cardiac output, stroke volume, and resting pulse. Highly trained athletes' bodies have a remarkable ability to compensate for blood loss, and they may not manifest the usual responses to hypovolemia, even with significant blood loss. An athlete with a heart rate of less than 100 beats per minute may still have a relative tachycardia. The normal hypervolemia that occurs with pregnancy means that it takes a greater amount of blood loss to manifest perfusion abnormalities in the mother, which also may be reflected in decreased fetal perfusion. Specific medications can affect a patient's response to shock. Review these examples of medications and their potential effect on the patient response to shock and its treatment. Patients suffering from hypothermia and hemorrhagic shock do not respond as expected to the administration of blood products and fluid resuscitation. In hypothermia, coagulopathy may develop or worsen. Core body temperature is an important vital sign to monitor during the initial assessment phase. Rapid rewarming with appropriate warming devices, heat lamps, thermal caps, heated respiratory gases, warmed intravenous fluids and blood will generally correct hypotension and mild to moderate hypothermia. Patients with pacemakers or ICDs with pacemakers are unable to respond to blood loss as expected. Their heart rate may remain at the device's set rate regardless of volume status. In many of these patients with myocardial conduction defects, additional monitoring is required to guide fluid therapy. Many devices can be adjusted to increase heart rate if clinically indicated. Inadequate volume replacement is the most common complication of hemorrhagic shock. Patients in shock need immediate, appropriate, and aggressive therapy that restores organ perfusion. An undiagnosed source of bleeding is the most common cause of poor response to fluid therapy. Be persistent in identifying the source of blood loss and consider the need for surgical intervention. Monitor the patient's response to resuscitation, including urinary output, central nervous system function, skin color, and pulse and blood pressure, with sophisticated techniques when possible. For elderly patients and patients with non-hemorrhagic causes of shock, consider early transfer to an intensive care unit or trauma center. When a patient fails to respond to therapy, consider other potential causes, such as cardiac tamponade, tension pneumothorax, ventilatory problems, acute gastric distension, myocardial infarction, diabetic acidosis, hypoadrenalism, and neurogenic shock. One of the most challenging situations a trauma team faces is managing a trauma victim who arrives in profound shock. Identifying and controlling the site of hemorrhage with simultaneous resuscitation involves coordinating multiple efforts.